Good evening, everyone. So just wait for everyone to go get the notification. Okay. Good evening, good evening. Hi guys, we're a couple of minutes late. I'm actually just waiting for load shedding. It's South Africa. Just waiting for my lights to actually go on here because I'm sitting with artificial lights here to try and get some sort of so you can actually see my face. So yeah, tonight we're speaking to Dr. Van Zyl. He's from Wijnland Fertility Clinic, and I think he's waiting for me. I'm just gonna send him an invite now. So we're talking about endometriosis, and there's a lot of the extent of it. So we're gonna speak to Dr. Van Zyl from Wijnland Fertility Clinic, and I'm just gonna wait for him to accept our invitation. And then, yeah, so while we wait, don't forget we've got the event on the 21st of this month. We've only got 3 tickets left, guys. It's 250 rand a ticket. Hi, Dr. Van Zyl.
Yeah.
I'll be with you. Hi there. I'll be with you in 1 minute. Just letting the ladies know. Yeah, so we've got the event on the 21st. It's at the Vineyard Hotel. We've got 3 tickets left. It's 250 rand. We'll have Q&As with doctors. There's some goodie bags, and you guys can also win free consultations. So if you want a ticket, please let me know about it. Please DM me for that. So tonight we are talking to Dr. Van Zyl. Dr. Van Zyl is a fertility specialist at the Wijnland Fertility Clinic. Sorry, he's out in Stellenbosch. Am I correct?
I'm a gynecologist and obstetrician. My practice is at Wijnland Fertility Clinic in Somerset West, where I practice, and I have a special interest in surgery and endometriosis, but I am affiliated with Wijnland Fertility.
Okay, great. So, yeah, we're speaking about endometriosis, and I understand you've got quite a bit of knowledge. My lights just went on, so you can actually see me now. Thanks. So, yeah, you've got quite a bit of knowledge or background with endometriosis. And like I said, it's a topic that, yes, it gets discussed, but we don't actually know the extent of endometriosis and how bad it can be and how women suffer with endometriosis. And they don't even know they're suffering with endometriosis. They're just thinking it's a bad period.
Yeah.
So we're going to get into the first question. We've got quite a lot of questions for you tonight. First one, so the first one is, what is endometriosis?
Yeah, as you mentioned just now, I mean, endometriosis is a very relevant topic, and but the diagnosis needs to be made accurately. Now, endometriosis, the lining of the uterus is called the endometrium. And endometriosis implies that the tissue, the lining of the uterus called the endometrium, that tissue is then ectopic, meaning it's in a different location. So it could be outside of the uterus, in the pelvis, on any of the organs there. So to answer your question, the definition is endometriosis is endometrial tissue occurring outside of the cavity. And yeah, we can discuss that further just now, but that's what endometriosis is in a nutshell.
Okay, what are the causes of endometriosis?
Now that is $1 million question, because there's, as you've learned in life, there's nothing is ever that simple. So if you look at the most, well, the theory that's most often used, or that it's most frequently ascribed to, is called the Sampson's theory, and that refers to retrograde menstruation, and that means whilst you're menstruating, the endometrial tissue or the menstrual fluid can flow backwards through the tubes into the pelvic cavity. So that is the theory that was adhered to mostly for many, many years, and it still remains applicable. But we know endometriosis is a very, it's a tricky disease. And we know if you look at research done at the moment that in itself cannot explain it.
Yeah.
Only that.
Yeah.
Because endometriosis has been found in premenstrual girls. So if you only stick to the let's say the backflow of the endometrial tissue through the tubes, the retrograde menstruation, that would not explain endometriosis in a young girl prior to starting her periods. And that section or subdivision of endometriosis seems to be caused by either abnormalities in the immune response locally, certain of the immune cells, the cells that maintain local immunity, certain genetic factors, environmental factors. So was certain tissue that remain from the embryonic state. So there's a long list of things. So to answer your question, firstly, backflow of menstrual fluid accumulating there, and then other factors, like I've just said, the immunity, hormonal, genetic, and all that. And because it's interesting to note that if you look at this backflow of menstrual fluid, 90% of women have that. You will see menstrual fluid in the pelvic cavity in 90% of women, and 90% of women does not have endometriosis. So we know that's not the only cause.
Yeah.
So difficult question, but I answer your question.
Okay. What are the symptoms of endometriosis?
Yeah, so as I just said, endometriosis means the lining of the endometrial tissue occurring outside the uterus. So predominantly it occurs in the pelvis. So it could be behind the uterus, on the cervix, on the ovaries, on the tubes. But it can also occur on the bladder, in the lining of the vagina, between the vagina and the rectum. It can occur on the colon, and then it can also occur outside the pelvic cavity. Like, for instance, 2% of patients with endometriosis will have endometriosis of the appendix. But it can occur outside, even on the diaphragm and in the lungs. But mostly it's in the pelvis. Now, if you look at the symptoms, because of the varied location of endometriosis, the symptoms can be varied. But what we usually or mostly see is painful periods, very painful periods, and usually periods that are painful now. I mean, that is worse now than it was before. So painful periods, heavy bleeding, irregular bleeding, some women with infertility or subfertility. But if it occurs on the bladder, certain bladder-related issues, and then if it's on the bowel, that we quite frequently see, that if it occurs on the rectum specifically or behind the uterus, low down, just above the rectum, we also see patients with severe pain or discomfort when they have a bowel motion with defecation. So even though the symptomatology is varied, it's difficult to tell you that if you have certain, say you have these 5 symptoms, that it is definitely endometriosis, because a certain number of patients with endometriosis are asymptomatic, meaning they don't have any symptoms at all, and it's a chance finding when you do a laparoscopy. But to help your viewers, if you have painful periods that are becoming worse over time, even though you've had treatment, and we haven't discussed treatment yet, but painful periods, heavy bleeding, and pelvic pain, chronic pelvic pain, discomfort with intercourse, then you should seek help. To me, I gave a lecture a while ago where I emphasized that you need to seek help. You need to suspect that you have a problem, and you need to see someone who's prepared to treat it, and if it's not treated adequately, to then refer and seek specialist help.
Okay. And then, when does one seek medical help?
Yeah. So before I answer that question, may I just quickly refer to the treatment of endometriosis? So, because often people think that all endometriosis should be treated surgically, which is not the case. So if you see a patient where you suspect endometriosis, I'm giving you an example. A lady in the early 20s come to see me with a history of worsening pain during periods, pelvic pain, pain with intercourse, or any of the symptoms we've discussed. I would then do a proper clinical, a medical history and a clinical examination. And if you suspect it, initially, treatment would entail hormonal treatment like a contraceptive pill or anti-inflammatories. If that is not adequate, you can then go to certain progesterone pills that we can discuss that later. Certain progesterones are more specific in inhibiting the growth and the local inflammation that the endometriosis causes. So first line treatment would be something as simple as anti-inflammatories or the pill or then the progesterone. If this is not adequate, but further treatment, medical treatment, I think, in my opinion, should be done by a specialist. Yeah. That briefly covers medical treatment. And then surgical treatment is definitely an option, but it's a selected subgroup of patients, and you can tell me if you'd like to discuss that a bit later.
Okay. How is endo diagnosed? I think you touched on this a bit. Did you?
Yeah, difficult. You need to suspect it. You need to have a suspicion dealing with it. So back to the basics: proper history, good clinical examination. But endometriosis is an enigma. There's not necessarily a direct correlation between the extent or the stage of the disease and symptoms. I've seen patients where they have an early stage of endometriosis with severe pain and vice versa. So the diagnosis, firstly, you should have a high level of suspicion. Clinical examination can be misleading, but you might find tenderness with the vaginal examination or internal examination, tenderness on the cervix, tenderness behind the cervix, especially the ligaments supporting the cervix at the back. It's called the uterosacral ligaments, which is not important to remember, but the medical professional that examines, that is where they would look. So that would be just behind the cervix, tenderness there. You might feel nodules. If it's endometriosis, can be superficial and deep. So if it's deeper endometriosis and it forms like a nodule, like a little growth in the vaginal wall, for instance, or just on top of the rectum, you might be able to feel that. So clinically, certain things. Imaging is more difficult. Most gynecologists would use ultrasound, and specifically vaginal ultrasound. So with a vaginal ultrasound, there's certain signs that you look for, but you need to train yourself, and obviously a more experienced ultrasonographer would be able to make the diagnosis earlier. It's not always easy or possible to diagnose superficial endometriosis, and it's usually if it's more complicated. And then some units have radiologists specializing in this, also MRI. Oh. So this is not ultrasound and MRI. The gold standard remains a laparoscopy, where we do a scope. We use a minimal invasive or keyhole surgery, and we under anesthetic, and you do the scope, and with a camera you go and you assess the pelvic cavity, and that remains the gold standard, I would say, to make the diagnosis, confirm it, and then plan further management. Okay.
And that's a quick surgery for women that's wanting to go this route, or having to go this route?
Yeah, quick, relatively, depending on what you find. I always counsel if I suspect endometriosis, and I usually tell them that if you do a laparoscopy and you find endometriosis, then that confirms the diagnosis, and that gives you the opportunity to make the diagnosis, stage it, and treat it. I feel quite strongly about it that if you don't know how to manage it and how to operate on it, then, or not just surgery, but the management, then you should rather refer the patient. So my aim when I do a scope is to confirm the diagnosis, stage the disease, and treat.
Yeah.
So, yeah.
Okay, perfect. And then, at what age is endometriosis identified?
Yeah, another very, very important question. Back in the day, not back in the day, as in now, but as still very recently, I attended the International Consensus meeting last year in France in September, and there was a study presented done by a lady, a professor in Italy, who did this study in correlation with certain schools and primary health institutions there. And this confirms previous work done, that the diagnosis of endometriosis is often delayed by 7 to 12 years because not enough effort is put in, or to make the diagnosis earlier, trouble taken. So 7 to 12 years. So say for instance, you have a teenage daughter of 17 with severe or with painful periods. And this was shown in this Italian study where they said most people would tell our family, we just battle with painful periods, you'll get over it and you'll be fine. Yeah. And then by the age of 24, 25, when it's severe disease, then only. So my approach is that if you suspect, I mean, obviously, and by that I also feel strongly that not everybody should have laparoscopies done, scopes done, but you should suspect the disease. So the earliest that I've personally have made the diagnosis was it was a family member of one of my colleagues, where two girls, 15 and 16 years old, where the diagnosis was made. So it's usually that it could occur that early, start out that early. But predominantly, it's usually more occurs, or the prevalence is highest between the age of 25 to 35. But it's often only when patients present with complicated disease or, persisting pain or whatever, that the diagnosis is made, because then only the investigations is done. So I have a very high index of suspicion.
Yeah. I'm going to ask you the next question, but I'm actually going to tie it in with the previous one as well. So I'm asking you, how does fertility, how does endometriosis affect your fertility? But I'm also going to ask you is that if a diagnosis is made earlier with endometriosis, could it help with your fertility in the end? As in, like, when you're in your teens or something.
Yeah, you're asking all the relevant, very difficult questions. This is a broad question that has many things that we need to discuss. So firstly, we need to quickly address staging of endometriosis, because some people think that if it's more serious, the more serious stages, stage 3 and 4, moderate to severe disease, it has other implications compared to early stages of the disease, stage 1 and 2, where it's more superficial, early stage disease. So endometriosis, if you look at the general population, about 10% of women have endometriosis. If you look at the subgroup of patients where they present with infertility, which is a subgroup, specialized subgroup of patients, up to 50% of women presenting with infertility have endometriosis. So we know there's a direct link, but it's important to realize that endometriosis is not the only cause of infertility.
Yeah.
Because some people sort of assume that if you battle with infertility, if you have a problem with subfertility, it equals endometriosis. That's not the case, but as I said, up to 50% of patients with infertility do have endometriosis. So different theories on how it affected. superficial endometriosis, stage 1 and 2, and there are many classifications, and I'm not one of them as absolute, but just for the sake of this discussion. So early stage endometriosis means it's superficial, and that does not necessarily cause mechanical obstruction, like with the more severe grades of disease where there's adhesions and tubal damage and all that kind of thing.
Yeah.
But endometriosis is an inflammatory process, and there's a lot of chemical changes on the surface of the lining of the pelvis and the ovaries and the tubes, which has a detrimental effect on the function of the pickup of an egg cell, how sperm is transported. So in that way, it could play a role. So, just flip side of this coin is I earlier said that not everybody should have surgery, but there were studies done where if an initial laparoscopy is done, the diagnosis is made and treatment is done during the same procedure, that in those patients you see a higher spontaneous pregnancy rate within the first 6 months of surgery. So we do know that even if it's early stage disease, if it's addressed, that the ability to fall pregnant improves. So in the early stage, it's more this the superficial endometriosis. There's a chemical problem with relation to immunity, pickup, sperm, implantation, all of that. With the more severe stages of endometriosis, it could be related to physical damage to the tubes and the ovaries and adhesions. I mean, it's quite upsetting to see what we sometimes see. Endometriosis can be a devastating disease. It can do a lot of physical damage. Yeah. So those would be the two groups: the earlier and then the more progressed disease.
Yeah. Okay, so the next one is, what treatment options are available for endometriosis? Okay,
so what is important there is to distinguish between or decide what is the aim of treatment. So if I see a patient presenting with endometriosis, especially, I'm not talking the kind of referrals we see with severe endometriosis and debilitating pain. If the aim of treatment is pain management, you would follow certain management steps. The moment fertility, subfertility, or fertility preservation becomes part of the decision, your approach is different. Because if, for instance, if you do surgery in a patient that presents with pain and the goal is to treat pain, you need to remember that if this particular person has a fertility wish, you can do, if surgery is not done properly or done too extensively, you could do harm. So surgical management should be done by a specialist in endometriosis surgery. But treatment otherwise would be medical treatment. That's what you were asking, treatment for endometriosis or the fertility?
I just think endometriosis on a whole as well. Yeah.
That we've discussed earlier. If it's approached endometriosis and the pain and bleeding abnormalities, it would be anti-inflammatories, the pill and progesterone. And if when it comes to fertility treatment, then the endometriosis will be treated medically. But if it warrants, there are certain checklists that you need to go through. If it warrants surgery, then the surgery is needed as well. In early stages, most patients should suffice with what we call ovulation induction, where we give the medication to cause ovulation. And then at Wijnland, we refer to a home plan, meaning we treat with medication to induce ovulation, and then the couple have timed intercourse at home. The next step would be artificial insemination or IUI, intrauterine insemination, that could increase or improve the success rate. And then if that does not work, then you obviously discuss it with your fertility specialist, and you can move on to artificial needs or IVF.
Yeah. Okay. And The next question is symptoms, pain grading. What is the relation?
Sorry, symptoms?
Sym- the symptoms and pain grading. What is the relation?
Yeah, that's a difficult one as well. It's difficult to quantify pain. But as I said, I think I mentioned this earlier on, there's not necessarily a direct correlation between the stage of the disease and pain. The primary cause for the pain is the local inflammation and the chemical changes associated with that. But there's also a change in how the nerve endings function in the area of inflammation. It's been shown that to keep this, to try and put this simply, the nerve endings change so that they are more prone to receive pain information and relay that to the brain than doing a function towards the end organ. So they receive information more than they deliver. So those patients are more sensitized to pain, and they feel pain way more intensely. Yeah. Then, like with chronic pain, pain can centralize. So if you bombard your spinal column and your brain with pain from the periphery for long enough, it can cause changes in your central perception of pain. And that is treated in a different way. So the whole pain management can be quite tricky. Fortunately, in the majority of patients, if you start out with what we've discussed earlier, in most patients, you see quite dramatic and fast pain relief. So the patients that I see on referral are usually the patients where medical treatment has not been successful, and especially with deep endometriosis, then surgery is indicated, and it's quite satisfying to see how patients see an improvement in quality of life once you've operated on the deep endometriosis. Endometriosis behaves itself like a cancer, but it's not a cancer. Yeah. So you can also see endometriosis infiltrating or doing damage to the nerves, the nerves in the pelvis, and that obviously needs way more specialized surgical treatment.
Okay, and then we got our last question is, can lifestyle affect endometriosis?
Yeah, it's difficult to say because it's very difficult to prove that scientifically. But yeah. A healthy lifestyle does improve your perception of pain. We've seen earlier on that even girls with just painful periods, if they start exercising, you see an improvement. But it's a difficult question because it's difficult to prove. But we know, I mean, we all, in this day and age, we all try and have a more holistic approach. And I think it's underestimated what the effect of lifestyle, but it's difficult for me, and I think it's not quite possible to give you a definite scientific answer to confirm that in a specific style could cause endometriosis. It's more based on the different etiologies we've discussed earlier.
Okay, that's perfect. Thank you very much, Dr. Van Zyl. I just like really thank you for taking your time out to do this talk with us. It's been very, very informative. We've had lots of questions for you. Sorry that it's under the circumstances, unfortunately. Like I said, we're living in South Africa. I've had to do it by, I don't know what happened, but my lights went off as well again. So, but we did it. So thank you very much. If you could just please leave your details with the ladies. So anyone that's dealing with endometriosis that'd like to see Dr. Van Zyl, he's at the Wijnland Fertility Clinic. You can contact him, and if you could just leave your details for us, please.
So my practice at Wijnland, to contact Wijnland Fertility, you can contact, you've got the details on the website. So you can contact them directly and then make an appointment with me. And if it would be easier for you to see me at my practice at Vergelegen, it's at Vergelegen Mediclinic in Somerset West. But yeah, you're welcome. I'll gladly be of help.
Awesome. Thank you. So I've got a few questions for you, but what we can do is we can send it straight through to Wijnland or to Dr. Van Zyl, and you can then liaise with him. So thank you very much, everyone, for joining. And thanks again, Dr. Van Zyl. Have a great evening
You've been-
further. Thank you. Thanks. Bye.